Greetings. Let me share with you what you need to know as an endoscopy nurse or as an endoscopy technician about stomach anatomy and changes that happen in the stomach due to various diseases. So let us first look at and learn stomach anatomy. Let me go through step by step. The esophagus enters into the stomach. That inlet is known as gastroesophageal junction. The area below the gastroesophageal junction is cardia. And then you will see the fundus. And then as you come down, you notice the body of the stomach. Body of the stomach is where you have longitudinal folds that secrete acid and pepsin to digest the food. And the body is separated by incisura from the antrum. Antrum is the one that does the grinding of the food. And then the outlet of the stomach is known as pylorus. From there, you enter the duodenum. You also notice two walls, the lesser curvature on the right side of the stomach and greater curvature on the left side of the stomach. So this anatomy is important for you so that when the endoscopist reports that he has taken a biopsy or noted a finding, he will relate to these areas. Now let us look at a patient with dyspepsia, a discomfort in the upper abdomen related to meals. And when you perform endoscopy, what all will you look at? What I've done is I've used the station of the endoscope and a picture to show what you will see depending upon where the endoscope camera is located or the tip of the endoscope is located. So as you enter the gastroesophageal junction and station at the gastroesophageal junction and look down, you see the cardia. As you go down, you see the upper 1/3 of the body of the stomach, and notice the long parallel folds of the stomach. These are the folds that secrete acid and the pepsin that digests the food. Middle 1/3 of the body, again the folds are seen, and lower 1/3 of the body where the folds are just tapering to enter the antrum. So you can see the antrum. And then as you go closer to the outlet, you see the opening called pylorus. And then what we do is we draw the scope back into the antrum, and then look up to see the incisura. Incisura is like a ridge that separates the antrum from the body of the stomach. And as you look up along the lesser curve, you see the lower 1/3 or lower half of the lesser curve and upper half of the lesser curve close to the GE junction and cardia. And then as you rotate the scope, you will see the fundus of the stomach. And then you push your scope and keep looking at the upper 1/2 of the greater curve, and a little more scope pushing, you will see not only the lower half but the entire stomach in a retroflexed view. Then you straighten the scope, go back to the antrum, and then look at the pylorus, and then peep through the pylorus into the first portion of the duodenum. So we have learned what all an endoscopist does and looking at different sections of the stomach. So when you have a patient with dyspepsia or pain related to eating, let us look at what all findings you may notice. In majority of the patients, you may not see anything. The stomach looks normal or a little bit irritated, and in these patients, one should rule out whether they're taking non-steroidals, like ibuprofen, Motrin, aspirin, etc., or they have Helicobacter pylori infection. These are the things we should be looking at. And we will talk about how do you find Helicobacter pylori. And regarding ibuprofen, Motrin, Brufen, etc., you ask this history whether taking any medications. Sometimes you may see these red streaks with yellow streaks in the middle. These are called erosions. Erosions are breaks in the lining, but the breaks are not deep enough to go through the muscularis mucosa. We'll learn about muscularis mucosa later on, and that leads to an ulcer. Here is an ulcer, and whenever you see an ulcer, again think about Helicobacter pylori, think about non-steroidal anti-inflammatory drugs, and also we should rule out cancer. Sometimes you may see cancer where the stomach becomes contracted, it does not distend, the folds become thick, large ulcers. You may also see someone where you don't see any folds. Here, you're in the mid body of the stomach. Normally, you should see folds, the gastric folds, and these are atrophied. This is gastric atrophy. This could happen because of Helicobacter pylori infection or because of autoimmune gastritis. Now, next is whenever you're doing endoscopy, the endoscopist tries to do some biopsies. And we go through what is called Sydney protocol biopsies. How do we go about taking those protocol biopsies? We take 2 to 4 biopsies from the antrum and place them in jar A. That is from the antrum. Next, we come back and take biopsies from the incisura and put them in a separate jar called jar B. Then you come up and take biopsies from the lesser curve and take again 2 to 3 biopsies, that is, put them in jar C. And finally, you take biopsies from the greater curve of the body of the stomach and place them in a separate jar, jar D. And this will help whether the patient has gastritis, gastric atrophy, or intestinal metaplasia, starting in the antrum, localized to that, or extending up into the lesser curve and also into the greater curve. The larger the area of atrophy and intestinal metaplasia, the higher the risk for that patient to develop gastric cancer. That's why these mapping biopsies are important. We are taking 4 biopsies. You could actually save and limit the number of biopsies by taking antrum and incisura in one jar and lesser curve and greater curve in a separate jar. But if you really want to do a protocol biopsies, Sydney protocol biopsies, you should follow this jar A, B, C, D, antrum, incisura, lesser curve of the body, and greater curve of the body. Now, let us look at when you have a patient with bleeding, what do you see? You may see blood, old blood or fresh blood, a lot of clots. You should be prepared to make sure that to suction that blood and make sure that the patient doesn't get aspirated. Important to keep the patient's head under the bed elevated or even have the patient intubated by the anesthesiologist. And you may see ulcers. Sometimes you may see actively bleeding ulcer or a clot there or a visible vessel. Or sometimes you may see just like a watermelon stomach. This is called gastric antrovascular ectasia. You may see in a patient with cirrhosis varices in the stomach or fundic varices. So these are the different findings, or you may see cancer also. So now let us look at a patient who is vomiting. When you have a patient with vomiting, they may have food in the stomach. Important to avoid aspiration risk in these patients. So it is better to have anesthesia intubate the patient so as to avoid the risk of aspiration. Aspiration can be very risky. And when you have a patient with a food in the stomach, first thing is you make sure that there is no obstruction to the pylorus or into the duodenum. Check for stenosis. Or the patient may be having a weak stomach or gastroparesis. So with that, let us learn about a little more about what happens to the stomach when you eat. It goes through three phases. When you eat, what happens is the fundus and the body of the stomach tries to accommodate until you feel full or you get to the point of satiation or satiety, and then you stop eating, and the gastric pacemaker starts motor activity of the stomach, and the antrum and the body of the stomach start grinding. And then once the food has been ground to very small particle size, then the pylorus opens and the stomach slowly empties. In normal people without gastroparesis, by 4 hours you should empty more than 90% of what you have eaten. And this could be tested by gastric emptying study, where you give a radio-labeled material, either in the form of a Big Mac or with eggs, and see the emptying of the radio-labeled material by putting them on under a radio um, activity measuring counter. I hope this is helpful. Thank you.